Hello, and welcome to Early Lyme Disease. The goals for this module are listed here. I'm Dr. Elizabeth Maloney. I developed and narrate this module. I have no conflicts of interest to declare. During this module, we'll consider 3 different clinical scenarios. The first 2 involve patients with a rash, and the third focuses on a flu-like presentation. Imagine you encounter this child in your office. Knowing that she's had this rash for 3 days, do you have enough to go on, or should you gather more information before making a diagnosis and treatment plan? You absolutely need to learn more. Early Lyme disease is a clinical diagnosis. To establish that it's the correct diagnosis for this child, you should investigate elements of her history that either support the diagnosis or suggest an alternative one. In addition to asking about the duration and nature of the rash, you should assess her overall risk of Lyme disease. Epidemiological data is often used to identify risk. By comparing your patient to known population patterns of Lyme disease, you'll have a better sense of her overall risk for the infection and better able to judge if her rash is indeed due to Lyme disease. Her family history may provide useful information. You might discover a predisposition towards an alternative diagnosis in the differential, or you may learn that another family member had Lyme disease or another tick-borne illness. Because family members tend to have similar exposure to ticks, a positive history in one would make Lyme more likely here. So, from an epidemiological perspective, what do we know about Lyme disease? This bar graph depicts almost 20 years of CDC surveillance data, and it demonstrates a trend for increasing case numbers that looks to be leveling off. It's important to understand that these values are qualitative, not quantitative. Why merely qualitative? It's because there's significant uncertainty regarding the annual incidence of Lyme disease. Combining data from CPT databases, large diagnostic labs, randomized phone surveys, and surveillance case reports, the CDC estimates that more than 300,000 new cases of Lyme disease occur annually in the U.S. This value is 10 times higher than what is reported through the surveillance system. Considering the inherent weaknesses of the reporting system, the difference isn't particularly surprising. This map depicts the location of individually reported surveillance cases. It was generated by placing a dot on the map for each reported case of Lyme disease. The location for each dot is based on the person's county of residence, which may not be where they acquired the infection. While your eyes might be drawn to the large foci of disease in the Northeast and Upper Midwest, take a moment to scan the entire map. You'll recognize that cases are scattered throughout the country, with clusters along the southeastern and Gulf coasts, as well as in areas near San Francisco and Seattle. So location is clearly a risk factor for Lyme disease, one that varies substantially across the United States. This graph plots surveillance cases by age group. School-aged children and middle-aged adults are at highest risk for Lyme disease. We know that young adults as a whole often engage in outdoor activities that would put them at risk, yet their case numbers are relatively low in comparison. Although it's tempting to speculate about why this is so, perhaps their immune systems are performing better than the others, the underlying cause for age-related variations in risk is unknown. Case reports are highest in the summer, yet as this graph demonstrates, reports are made throughout the year. The summer peak primarily represents cases of early disease, and it's likely that the majority of these had recognizable Erythema migrans rashes. EM rashes develop within 4 weeks of a bite. It's thought that bites from infected nymphal ticks are more likely to transmit disease than bites from infected adults. Given that nymphs are most active in the late spring and early summer, the June-July peak makes sense. Let's look at early Lyme disease from a clinical perspective. The typical incubation period is 7 to 14 days, but disease onset can occur within 2 to 30 days of a bite. In this acute stage, patients may be entirely asymptomatic, have an isolated Erythema migrans rash, or have a flu-like illness without a rash. The lucky ones have both a rash and flu-like symptoms. I consider them lucky because their Lyme diagnosis is unlikely to be missed. Constitutional symptoms include fever, chills, malaise, and fatigue. Headaches, muscle and joint pain, and neck stiffness are frequent, and paresthesias are not uncommon. Sore throats are occasionally mentioned in the literature. Findings of early Lyme disease include the telltale EM rash, lymphadenopathy, and pharyngeal erythema. The diagnosis is made on clinical grounds because laboratory testing is unreliable in early disease. Antibiotic therapy is required. Turning attention back to your 7-year-old patient. From her history, we learn that she lives in a wooded development within a Lyme endemic area of Northern California. In addition to her rash, she's had fevers, headaches, and fatigue. It's the first week of July. The Erythema migrans rash is the hallmark of early Lyme disease. The rash most commonly appears as a solid-colored and generally oval-shaped lesion. EM rashes expand and clear over weeks. Although EMs will clear on their own, antibiotics hasten resolution. To satisfy CDC surveillance criteria, an individual lesion must be 5 or more centimeters in diameter. Most rashes are much larger than that, but this may not be the case when multiple EM lesions are present. The classic bullseye lesion has central clearing. This appearance is relatively uncommon. In fact, studies suggest that less than 20% of all EM rashes are bullseyes. So if that's all you look for, you're probably missing their target. More importantly, clinicians need to understand that many patients have no rash. CDC surveillance data documented that 30% of the reported cases lacked an EM rash. Even when present, EM rashes may not be instantly recognizable because the appearance of the rash varies from patient to patient. The range of potential colors is wide, anything from a faint salmon to a deep scarlet, and its location on the body may distort an EM shape. A literature review by Tibbles and Edlow focused on the presence or absence of central clearing. They found that central clearing was common in cases from endemic areas of the U.S., but was typically present in cases originating in Europe and non-endemic areas of the U.S. The authors didn't speculate about the underlying cause of this finding, but perhaps the variation could be related to differences between the infecting Borrelia species and strains. Or could it be that physicians working in endemic areas of the U.S. recognize a wider spectrum of EM rashes than their colleagues in other locales? Erythema migrans rashes need to be distinguished from several other lesions. The most common are listed here. In contrast to EMs, allergic reaction to tick bites appear within the first 24 hours and are usually gone within 48 hours. Depending on their location, EMs may be mistaken for tinea or eczema. Some EM-like rashes may be manifestations of other infections, such as STAR-I, Southern Tick-Associated Rash Illness, or Borrelia miyamotoi disease. Of these 6 rashes, which are Erythema migrans? Pause the presentation to give yourself time to look them over. The answer will appear when you resume the program. Were you surprised? In darkly complected patients, like the person on the left, EMs may masquerade as a bruise. EM rashes on the lower leg may have small vesicles at the center of the rash. EMs, like the one on the far right, could easily be mistaken for cellulitis. That's an important mistake to avoid because antibiotics commonly prescribed for cellulitis, such as cefuroxime, are ineffective for Lyme disease. In situations where differentiating between these two are difficult, it's prudent to prescribe cefuroxime or amoxicillin clavulanic acid because these agents are effective for both conditions. What do you think? Are patients with early Lyme disease twice as likely to have no EM than to have a bullseye? Pause the program to consider the facts we just covered. What do you think? Does your 7-year-old patient have Lyme disease? Given her multiple risk factors and her positive clinical findings, the answer is yes. As I mentioned earlier, early Lyme disease is a clinical diagnosis. Results from serologic testing, ELISAs and Western blots, are generally unhelpful. Serology measures antibody levels, which are indirect markers of bacterial exposure. But the humoral response to the infection may take weeks to develop. Because serologic results are likely to be falsely negative at this stage, serologic testing is not recommended for diagnosing early disease. See the module on serologic testing in Lyme disease for more details. Let's look at the pathophysiology, from tick bite to established infection. From B. burgdorferi's perspective, being a vector-borne pathogen carries a distinct advantage over other routes of transmission. Thanks to the tick, the bacteria avoids one of our best defenses, an intact skin barrier. Moreover, tick saliva contains several components that aid transmission. Ticks feed over several days, which increases the likelihood of Lyme disease. To allow for prolonged feeding, tick saliva contains anticoagulants. The saliva also has anesthetic and antihistamine properties. Thus, the bites are painless and non-pyretic, which explains why most bites go undetected. As a zoonotic pathogen, Borrelia burgdorferi is able to infect a wide range of animals, including ticks, mammals, birds, and reptiles. To tolerate these different environments, the bacteria must be highly adaptable. In some instances, adaptation involves bacterial changes. In others, B. burgdorferi influences host processes to its advantage. Borrelia burgdorferi sensu stricto, the predominant agent of Lyme disease in the United States, is a member of the Borrelia burgdorferi sensu lato complex. This family tree is large and growing. Europe has 3 main species, as well as others that are less commonly seen. In the U.S., a handful of reports linked Lyme disease to non-Borrelia burgdorferi sensu stricto pathogens. The relapsing fever Borrelia miyamotoi, can also cause a Lyme-like illness. Clinical presentations may differ between species and strains. Serologic tests based on a single species or strain may be unable to identify antibodies to other species or strains. There's also evidence suggesting that antibiotic susceptibility may vary by species and strains. This diagram depicts basic components of the bacterium. 4 to 8 internal flagella are attached to the internal surface of each end of the outer surface membrane and transverse more than half the length of the organism. This arrangement allows for bidirectional movement, but reduces the exposure of the highly antigenic flagella to circulating antibodies. The genome consists of a single linear chromosome and up to 21 plasmids. This allows for rapid exchange of genetic material between organisms and gives rise to a large number of borrelial strains. Despite its genomic complexity, Borrelia burgdorferi lacks the ability to synthesize self-nutrients. A wide variety of lipoproteins are attached to the outer surface membrane. These outer surface proteins, or OPs, have different functions. The exact structure and number of individual OPs that are expressed on the outer membrane change over time. To establish a new infection, B. burgdorferi must avoid being killed by the host's immune response. Once again, the tick saliva comes to B. burgdorferi's aid. Immune modulators in the saliva inhibit the complement cascade, cellular responses, antibody production, and antibody-mediated killing. The bacteria itself causes an upregulation of IL-10, which not only suppresses resident immune cells, but also the function of immune cells that subsequently migrate to the infection site. It appears that Borrelia burgdorferi is able to block development of an effective antibody response. Usually, when the presence of a pathogen is detected, germinal centers form within lymph nodes and ultimately give rise to long-lived plasma cells. As the antibody response matures, IgM antibodies give way to IgG. This is the basis of immune memory, which reduces the likelihood of reinfection. However, research by Hasty and colleagues suggests that B. burgdorferi can interfere with this process. Using a mouse model, they found that the bacteria actively entered lymph nodes and disrupted the formation of germinal centers, such that long-lived plasma cells never developed. Thus, the mice continued to produce IgM antibodies, but never mounted an IgG response. Interestingly, serologic studies in humans have demonstrated that some individuals produce waves of IgM antibodies without ever seroconverting to IgG. In the immediate post-transmission period, Borrelia burgdorferi can evade circulating antibodies with the help of a specific tick salivary protein. To establish mammalian infection, the bacteria must express outer surface protein C on its outer membrane. However, this protein is highly antigenic, and circulating antibodies would easily recognize it and attach to the pathogen, as seen here. B. burgdorferi is able to prevent this from happening. It induces the tick to produce increased levels of salivary protein 15, which acts as a protective shield. As depicted in this second diagram, when salivary protein 15 is injected with the bacteria, it blocks antibody attachment to OpC, thus inhibiting antibody-mediated killing. The bacteria can also avoid the immune response by altering its appearance. Phasic variation is one example of that strategy. Here, the number of expressed copies of an outer surface protein is modulated in response to the bacteria's environment. This diagram uses OpC as an example. The bacterium has little need for it when it's in the tick's midgut, but the number of expressed proteins increases as it moves to the salivary gland and into mammalian tissue. Once infection is established, OpC expression is downregulated to avoid the attention of circulating antibodies. Borrelia burgdorferi migrates in the dermis via its flagella and the use of activated host plasminogen. When activated, the plasminogen dissolves cellular junctions, facilitating bacterial migration within tissues. As Borrelia moves through the dermis, it's followed by a host of immune cells. It's thought that the release of pro-inflammatory cytokines from immune cells produces vascular dilatation and visible erythema of the overlying skin. If that's true, what, if anything, does this suggest about the immune response of patients who never exhibit an EM rash? Getting back to your patient, in order to select an appropriate antibiotic regimen, you need to consider patient-specific factors, such as age and medication allergies. And you also need to know which antibiotics are likely to kill Borrelia burgdorferi. Clinical efficacy can be determined in clinical trials and through clinical experience. Let's look at the evidence from published prospective erythema migrans trials that were conducted in the United States. The primary reason for looking into the trial evidence is to see if one agent performs better than the others, because that would be clinically useful information. European EM trials are not included in this analysis. Most EM cases in Europe are caused by Borrelia afzelii, which produces a different clinical spectrum of disease than Borrelia burgdorferi, and may not disseminate as widely as B. burgdorferi. The 8 studies differed in several ways. The designs and execution were far from ideal, leading to inflated efficacy findings that are unlikely to be matched in community-based practices. The accepted first-line agents for treating erythema migrans patients in the United States are amoxicillin, cefuroxime, and doxycycline. It turns out that none of the U.S. trials compared all three agents simultaneously, but combining the individual trial data allows us to make that comparison. Because the trials differed in their designs and execution, this analysis took steps to supply some uniformity. The first was to determine the completion rates for each antibiotic arm of the 8 trials. The trials by Luger and Wormser and the doxycycline arm of the trial by Nadelman had non-completion rates equal to or greater than 20% and were therefore dropped from the analysis. Here's why. Although it's understood and accepted that the clinical trials are likely to enroll some subjects who failed to finish the study, when the non-completion rate is high, it's difficult to draw trustworthy conclusions. Biostatisticians commonly set the non-completion cutoff at 20%. A uniform approach to handling dropouts was needed. A variety of statistical methods exist. One approach is to consider only the outcomes of subjects who completed the study. Another is to fill in data for the missing. For example, you could assume that their status after their last visit never changed, a best-case scenario, dropouts are well, or a worst-case scenario, dropouts are ill. Given that many subjects drop out due to medication intolerance or treatment failure, and Lyme patients are known to relapse, the first two methods tend to overstate treatment success. To avoid doing this analysis took a conservative approach. Subjects who dropped out for any reason, medication intolerance, allergic reaction, treatment failure, or disease relapse, and loss to follow-up, were counted as failures. Outcome definitions varied between the original trials, but they were generally disease-centered. For example, subjects who cleared their rash but remained symptomatic were typically categorized as treatment successes. Since most patients won't equate ongoing symptoms with a success, this analysis used patient-centered outcome definitions. Success was defined as a complete resolution of the rash and all Lyme-related symptoms without evidence of relapse during the observation period. Failure was anything short of that. Applying these definitions resulted in the reclassification of some outcomes, such that they were reclassified from successes to failures. To illustrate the importance of statistical methodology, let's consider the results from an EM study that's frequently cited as the evidence that outcomes improve as time goes by. 61 subjects were randomized to receive 10 days of doxycycline. The middle column shows the results as reported using complete case methodology. Looking only at percentages, it does appear that the success rates improved significantly between 20 days and 30 months. However, on closer inspection, the absolute number of treatment successes is the same at 3 and 12 months. The percentage went up because more subjects had dropped from the trial. At the end of the trial, there were 8 fewer successes than at 12 months, but the shrinking denominator pushed the success rate higher. The right column uses a conservative approach to handling dropouts. Those who didn't finish the study for any reason were considered treatment failures. Although the actual number of successfully treated cases was higher with this methodology, the overall rate was lower. As you can see, the choice of methodology can bias findings and ultimately conclusions. 2 studies treated a total of 135 patients with 500 milligrams of amoxicillin 3 times daily for 20 days. The success rate was approximately 75%. 2 studies looked at 5 to 7 days of azithromycin. The combined efficacy was 75%. In the larger study, the relapse rate for azithromycin was substantially higher than for amoxicillin. This paper is often cited to explain why azithromycin is not used as a first-line antibiotic in the U.S. 2 studies investigated the use of 20 days of cefuroxime, 250 milligrams twice daily. Treatment was successful in 62% of the 78 subjects. 2 studies examined the use of doxycycline, 100 milligrams twice daily for 21 days. This regimen was effective in roughly 80% of the subjects. Only one U.S. trial investigated a 10-day regimen of doxycycline. The original study had an interesting design in that subjects who were judged as treatment failures at 10 days were automatically offered retreatment. After the first 10 days of doxycycline, 7 subjects were immediately retreated, and an 8th subject relapsed later on and ultimately received IV ceftriaxone. Thus, the success rate for 10 days of doxycycline was 64%. This table highlights a few key points. There isn't a lot of data to analyze. This means that the findings lack precision. Success rates are generally similar for the different agents. Although cefuroxime appears less effective, the difference may be due to differences in the trial designs. The cefuroxime trials had an observation period for 1 year, but outcomes for the other agents were typically determined after only 6 months. Disease relapse and progression is known to occur in Lyme disease, and longer observation periods would be more likely to pick up these poor outcomes. This may be why cefuroxime had a lower success rate. This analysis of the EM trials found that amoxicillin, cefuroxime, doxycycline, and azithromycin had similar and relatively low success rates. Additionally, the trial review revealed that subjects who were treatment failures in the Maserati, Nadelman, Luft, and EP trials were often retreated and subsequently improved. Certain clinical presentations were associated with an increased risk of long-term failure. Subjects with dysesthesias, paresthesias, increased irritability, headache, and/or neck stiffness, as well as those with a greater number of symptoms or more severe disease, were likely to be treatment failures. Subjects presenting with multiple erythema migrans rashes were more likely to be ill at the final observation point. The same was true for subjects who had continued symptoms and signs when active therapy ended. And of the 446 subjects in these trials, only 28 were children. Considering that children are at highest risk for acquiring Lyme disease, it's disappointing to see them so grossly underrepresented. Although the results from this analysis clearly differ from the original reports, they align nicely with the findings from the observational SLICE study. That study treated 63 EM subjects with 21 days of doxycycline and found that a third remained symptomatic at the 6-month endpoint. And while it's widely held that symptoms decline over time, neurocognitive complaints in the SLICE study actually increased by 9%. Based on the trial analysis presented here, we can conclude that the optimum agent and duration of treatment for erythema migrans patients has not been established. We can hypothesize that antibiotic retreatment is not unreasonable given its reported success in the analyzed trials. Risk stratification based on the initial presentation could lead to better outcomes provided those at high risk were managed differently, and those who had an incomplete response to 20 days of therapy might benefit from extending the duration of antibiotic treatment. This suggests that a planned post-treatment follow-up by phone or in person may be useful. Armed with this information, how would you treat your 7-year-old patient? She doesn't appear to be at high risk for treatment failure, and although short courses of doxycycline are unlikely to cause dental staining, her age makes doxycycline a less attractive choice. 20 days of therapy seems appropriate. Her parents should be asked to report how she's doing when treatment ends, with subsequent management being based on her therapeutic response. In case 2, You're faced with a 65-year-old hunter who presented in November with this rash. His known black-legged tick bite occurred at the Minnesota-Wisconsin border, and he happens to be diabetic. In addition to the rash, he's had fevers, chills, and generalized myalgias. After 2 days of amoxicillin, he was no better. It's now day 3, and he comes to see you because he actually feels much worse. What do you think might be going on? When cases take an unexpected course, it's important to reconsider everything, starting with the diagnosis. If this isn't Lyme disease, what other diagnoses are likely? Could he have cellulitis that's unresponsive to amoxicillin and complicated by his diabetes? Is this a different tick-borne illness or a combination of tick-borne illnesses? If the original diagnosis is correct, could this be a case where the infecting strain of B. burgdorferi is unresponsive to amoxicillin? Could the diagnosis and treatment be spot on and his worsening symptoms simply represent a Jarisch-Herxheimer reaction? You may recall that the classic Jarisch-Herxheimer reaction is seen in patients with syphilis and occurs immediately following the first dose of penicillin. Bacterial killing leads to endotoxin release, which can cause an abrupt onset of fevers, chills, and hypertension, followed by hypotension. This dramatic response clears over several hours. In contrast, the Jarisch-Herxheimer reaction in Lyme disease tends to be delayed. It may not occur until day 2 or 3 of therapy. Rather than a set list of symptoms, Lyme-related JH reactions involve an intensification of the patient's baseline symptoms. The duration is variable. The pathophysiology is unknown. Unlike Treponema pallidum, Borrelia burgdorferi lacks genetic coding for endotoxins. The current hypothesis is that Borrelia lipoproteins trigger an inflammatory response, and the increase in inflammatory cytokines produces the reaction. A review of the literature found that of the trials that mention this phenomenon, it occurred in approximately 15 to 20% of the subjects. In addition to Borrelia burgdorferi, black-legged ticks can transmit several other pathogens. Thus, a single bite can lead to multiple infections. The possibility of co-infecting pathogens can complicate the diagnostic evaluation. Many co-infections produce symptoms that overlap with those of Lyme disease, and the presence of a concurrent co-infection can result in a more severe illness. Treatment may also be complicated when additional pathogens are present. For example, babesiosis requires antimicrobials not commonly used to treat Lyme disease. It turns out this gentleman had both Lyme and anaplasmosis. Anaplasmosis is most frequently seen in the upper Midwest and parts of the Northeast. Amoxicillin is ineffective, which is why the patient continued to deteriorate. Because doxycycline covers both pathogens, it would have been a better choice. Overall, the mortality rate for anaplasmosis is quite low. The risk is substantially higher in the very young and very old. This gentleman required hospitalization, but thanks to doxycycline therapy, he made a full recovery. The take-home message from this case is that instead of focusing on Lyme disease, clinicians should think more broadly and consider the potential for other tick-borne diseases. Our final case concerns a 35-year-old gentleman who presented in June with the summertime flu. Specifically, he reported having fevers, chills, a severe headache, and myalgias for 7 days. These problems have worsened a little over the last week. He does not recall a tick bite, and he hasn't seen any rashes. He was previously healthy and lives in Pennsylvania, where there's a lot of Lyme disease. On exam, he appears ill but not septic. He has no rash and no nuchal rigidity. The differential diagnosis is fairly wide, including several viruses, bacteria, and a protozoa. The relatively stable course makes some entities less likely, and his residence in a high-risk state makes Lyme disease more likely. How might you manage this patient? Experts suggest that when patients in Lyme endemic areas present with symptoms of Lyme disease without an EM rash, that Lyme be strongly considered. They point out that serology is unlikely to be helpful in distinguishing Lyme disease from other infectious causes. Therefore, when in doubt, treat. How you should do that is unclear. There's no trial data to guide decision-making. Findings from the EM trials may not be applicable to non-EM patients. Doxycycline is the agent of choice because it covers other tick-borne illnesses, yet other first-line antibiotics may be equally appropriate. 20 days of treatment should be sufficient for those who lack neurological symptoms and are not severely ill. This gentleman's symptoms intensified on day 2. What do you think is going on? Is the diagnosis wrong, or is he having a Jarisch-Herxheimer reaction? In this case, it was a Jarisch-Herxheimer reaction, which spontaneously resolved, and the patient made a full recovery. In summary, Borrelia burgdorferi is the agent of Lyme disease in the United States. This zoonotic pathogen is highly adaptable and possesses several mechanisms for evading the immune response and establishing disease. Risk factors for acquiring the infection in the United States include area of residence, activities that increase exposure to ticks, age, time of year, and a positive family history of tick-borne diseases. Early Lyme disease has several presentations. The hallmark Erythema migrans rash has a variable appearance. Most commonly, it appears as a solid-colored oval lesion. Less than 20% of all rashes have the classic bullseye pattern, and 30% of all reported cases have no rash. Several antibiotics are effective against Lyme disease, but treatment failures are relatively common. While none of the first-line agents is clearly superior, doxycycline may be the preferred agent in areas where patients could be simultaneously infected with anaplasmosis. Based on trial evidence, amoxicillin, cefuroxime, and doxycycline should be given for at least 20 days. None of the trials used less than 20 days of amoxicillin or cefuroxime, and the single trial that employed 10 days of doxycycline was very small, and 36% of the subjects were subsequently retreated. The trials also suggest a need for risk stratification. Patients presenting with neurologic symptoms, severe illness, and multiple EM lesions are at higher risk of treatment failure. So are patients who remain ill at the conclusion of antibiotic therapy. It's possible that these groups would benefit from a different therapeutic strategy, but no trials have investigated this possibility. Treatment failures occur and require additional intervention. Thank you for viewing this module, Early Lyme Disease.